For my presentation, entitled Anti-vivisection and Anti-psychiatry, I will focus on the connections and opportunities for allyship between the anti-vivisection and anti-psychiatry movements. To begin with, I will put forth the position that the use of other-than-human animals in research, as well as symptom-based diagnoses and treatment in psychiatry, are all unreliable. From there, I will touch on incarceration and some of the many abuses faced by both psychiatrized people and other-than-human animals used in research, drawing on the similarities between some of those abuses, detailing the torture of other-than-human animals used in psychiatric-related testing, which some consider to be the cruelest experiments, and providing examples of how relying on those experiments is harmful to psychiatrized people. I will conclude with an analysis of suggestions for moving beyond these practices through the further development and funding of alternatives, suggesting actions we can all take, and a call for allyship. Before I begin, I feel it is important to note that nothing I say should be taken as medical advice. I do, however, encourage people to do their own research and come to their own conclusions. There have been many books written on all of these topics individually, and this is merely an introduction for connecting these issues, which I hope to expand upon later. Also, although my focus here is on psychiatry, I am not interested in upholding the usual distinction between it and other medical models. I recognize that the medical model of disability is usually oppressive and harmful. Psychiatry is just my experience and where I have the most knowledge. So if anything I say reinforces that distinction in any way, please let me know. First I ask, is testing on other-than-human animals reliable? Well, according to Dr. Francis S. Collins, who is the director of the National Institutes of Health, the use of animal models for therapeutic development and target validation is time-consuming, costly, and may not accurately predict efficacy in humans. Despite this, the NIH, who are partially funded by taxpayers, contributes billions of dollars every year towards projects involving testing on other-than-human animals. I would argue that what Dr. Collins admitted is greatly understated, given that, according to a 2012 article in New Scientist by geneticist Kathy Archibald and pharmacologist Robert Coleman, a recent study in regulatory toxicology and pharmacology shows that animal tests missed 81% of the serious side effects of 43 drugs that went on to harm patients. And the New England Anti-Vivisection Society states, the FDA reports that 92% of drugs approved for testing in humans fail to receive approval for human use. The failure rate has increased from 86% in 1985, in spite of all the advances and refinements intended to make animal tests more accurate. The fact is, species differ too greatly from one another for the test to be reliable. For example, though chimps are our closest animal relation with DNA almost identical to our own, the New England Anti-Vivisection Society says that more than 80 HIV vaccines that have proven safe and efficacious in chimpanzees, as well as other non-human primates, all have failed to protect or prove safe in humans in nearly 200 human clinical trials, with one actually increasing a human's chance of HIV infection. These studies also fail to take into account the conditions these other-than-human animals live in, and the effects that may have on results. Our living conditions differ greatly from theirs, with only a few exceptions approaching any sort of similarity, one of which I would argue is incarceration in psychiatric facilities, or what the system calls involuntary commitment. But before that can happen, the person is usually given a diagnosis. Which brings me to the next part of my presentation. Is psychiatry reliable? Those who are diagnosed are often told of a chemical imbalance in their brain, which medication corrects. But there is no test given that shows this, and these diagnoses are completely symptom-based, which is unreliable. The former American Psychiatric Association president, Loren R. Marsher, admitted to this in his resignation letter when he said, "The issue is what do the categories tell us? Do they in fact accurately represent the person with a problem? They don't and can't, because there are no external validating criteria for psychiatric diagnoses. There is neither a blood test nor specific anatomic lesion for any major psychiatric disorder. So where are we? APA as an organization has implicitly, sometimes explicitly as well, bought into a theoretical hoax. Is psychiatry a hoax as practiced today? Unfortunately, the answer is mostly yes." Now, these categories he speaks of are those in the DSM, or Diagnostic and Statistical Manual of Mental Disorders, which is where psychiatric diagnoses come from. Since there are no external criteria, what gets included within each new edition of the DSM is determined by debate among a task force. In a presentation, Dr. Stephen Wiseman, in what I can only assume was an attempt to add validity to this process, compared this to the debate around whether or not Pluto classifies as a planet. I think this comparison has the reverse effect and only reinforces how arbitrary these diagnoses are, and he completely ignores the fact that Pluto's classification has little to no effect on the vast majority of people, whereas criteria for psychiatric diagnoses affects us all. In this same presentation, he states that the chemical imbalance theory told to the public and patients has not been taught to psychiatrists in decades, and there are many examples of others in the field admitting to this being a lie, including Kenneth Kendler, who is known for pioneering research in genetic causes within the field. He wrote, "We have hunted for big, simple neurochemical explanations for psychiatric disorders and have not found them. We have hunted for big, simple genetic explanations for psychiatric disorders and have not found them." This lie of a chemical imbalance is said to be helpful to patients, but a 2014 study found that when people were told their depression was caused by a chemical imbalance, it did not reduce self-blame, it made patients more pessimistic about their prognosis, and even lowered their expectations for regulating their own moods. It did, however, lead them to view medication as more credible than psychotherapy, but I wouldn't consider that helpful. Even the former director of the National Institute of Mental Health, Thomas Insel, who recently left his position to go work for Google and is trying to use current technology for further surveillance of psychiatrized people, admits that the weakness is its lack of validity. Unlike our definitions of ischemic heart disease, lymphoma, or AIDS, the DSM diagnoses are based on a consensus about clusters of clinical symptoms, not any objective laboratory measure. In the rest of medicine, this would be equivalent to creating diagnostic systems based on the nature of a chest pain or the quality of fever. Indeed, symptom-based diagnoses, once common in other areas of medicine, has been largely replaced in the past half-century as we have understood that symptoms alone rarely indicate the best choice of treatment. Given this lack of testing and lack of evidence in abnormalities with the brain, despite it being a theory in one way or another for over 200 years, how can treatments that are meant to alter the brain be reliable? Many studies have shown that placebos work just as well, and in some cases better, than psychiatric medications in the short term, and others show people tend to do much better in the long term when not on medications. For example, a 15-year-long study that was released in 2007 showed that 40% of patients diagnosed with schizophrenia who were not on antipsychotic drugs showed periods of recovery and better global functioning compared to only 5% of patients taking antipsychotics, according to Accessibility News. And finally, another major reason why these categories are not accurate is they don't consider context. They take reactions to oppression, abuse, trauma, and other challenging issues we all face and transform them into symptoms without taking the root causes into consideration. At its core, psychiatry is a form of social control, and one of the more subtle ways it accomplishes this is through this decontextualization, because it keeps those of us who have been given a psychiatric diagnosis focused inward, believing there is something wrong with our brains, instead of focusing outward and recognizing the many things wrong in our society, which includes the suffering of psychiatrized people and other than human animals used in research. I would argue that the psychiatric system causes suffering the instant it diagnoses an individual by creating a false dichotomy with its biological model, which causes stigma. A recent article by Dr. Jonathan Abramowitz in The Behavior Therapist points to research which supports this idea and reports that research on public attitudes towards people with schizophrenia, for example, reveals that as acceptance of the biomedical model has increased in recent decades, so too has the desire for social distance from people with this condition. After that, psychiatrized people are at risk of being incarcerated in psychiatric facilities, while other than human animals used in research are incarcerated in laboratories. During their incarceration, both have harmful chemicals forced upon them. For psychiatrized people, this is referred to as involuntary treatment by the psychiatric system. This may include them being observed while taking a pill, as well as a mouth check to ensure they have swallowed, or an injection, while other than human animals are intentionally poisoned with chemicals that may later be branded as those medications in order to test their toxicity. Given that these studies on other than human animals are unreliable, I believe their suffering and death is completely unnecessary. Not only that, but relying on these studies also puts those in the human trials at great risk, which for psychiatric drugs obviously includes psychiatrized people. A recent example is the death of Augustin Leo Liu, who was diagnosed with schizophrenia and part of a clinical trial for Risperdal. The jury ruled that the company that makes the drug, Johnson & Johnson's Janssen Pharmaceuticals, and his psychiatrist, who the family alleges convinced him to enter the study for the all-too-common finder's fee, were responsible for his death. Since drug manufacturers within capitalism are like any other business, they push to have their products on the market as soon as possible, which is often before the long-term effects in human trials are known, putting everyone who is prescribed these drugs at risk. One example is an 18-year study by Nancy Cover-Andreasen, an American neuroscientist and neuropsychiatrist, who admitted that another thing we've discovered is that the more drugs you've been given, the more brain tissue you lose. The drugs here are antipsychotic medication, commonly given to people diagnosed with schizophrenia and bipolar. They also found that the prefrontal cortex doesn't get the input it needs and is being shut down by the drugs. That reduces the psychotic symptoms. It also causes the prefrontal cortex to slowly atrophy. To reiterate, these are drugs that the psychiatric system claims fixes something that is wrong with the brain, for which there is no evidence, but in actuality these drugs cause parts of the brain to atrophy. This is quite literally a chemical lobotomy. And within the same article, she also admits, the reason I sat on these findings for a couple of years was that I just wanted to be absolutely sure it was true. My biggest fear is that people who need the drugs will stop taking them. I would argue that the truth should always be told, and if it's going to lead people to stop taking medications, then we need better support to help those people gradually and safely come off of it whenever possible. Also, I think this statement speaks volumes to the level of secrecy that surrounds psychiatry. These drugs even caused a whole new condition known as tardive dyskinesia, which results in involuntary repetitive body movements, and, according to current psychiatry, there are no FDA-approved drugs for treating it. It's not just antipsychotic medications either. Antidepressants have been linked to inducing apathy, worsening depression, and increasing a person's risk of suicide. All psychiatric drugs have very harmful side effects, and even the attended effects are harmful, with many of the drugs actually worsening the conditions they are supposed to treat, as the brain tries to balance out the changes these drugs cause. For a detailed description of this process, check out Bonnie Burstow's book, Psychiatry and the Business of Madness. Traces of all these drugs also end up in our water, and according to a study done in Sweden on oxazepam, typically prescribed for anxiety, the current levels of this drug found in the water dramatically change the behavior of fish, making perch less and even antisocial, which put them at a greater risk for predator attacks. Issues like this could lead to population depletion and upset the balance of affected ecosystems. Along with being used to test toxicity in new medications, other than human animals also suffer in many ways for so-called advancements in the mental health field. According to the New England Anti-Vivisection Society, animals are subjected to food, water, and sleep deprivation, sensory deprivation or overload, long-term physical restraints, social isolation, maternal separation, electric shocks, limb amputation, and brain damage and manipulation through the use of electrodes surgically implanted into the brain. To study behaviors and experiences, psychology research typically requires animals to be conscious and aware, and as such may be considered the cruelest of animal experiments due to the high degree of pain and suffering involved. Animals can remain in distress for a long length of time, since they are often subjected to invasive procedures that they then must recover from in order for their behaviors and experiences to be studied in relation to the resulting injury. In these quotes, we find even more similarities between the treatment of these other-than-human animals and psychiatrized people. For example, a 2011 report in Ontario, Canada, where I am from, found that restraints were used for 1 in 4 psychiatric patients, and that, since reporting of control interventions is not required, the findings likely represent a conservative estimate, and the researchers believe rates of control interventions likely do not vary much across the country. Restraining of psychiatrized people includes being strapped down to a bed, being physically held down by other people, fast-acting medications to sedate the person, and seclusion or confinement in a room. The last example also being comparable to the social isolation other than human animals experience. The very act of incarceration in a psychiatric facility, with very limited and in some cases no visitation rights for family and friends, I believe is also comparable to social isolation, as well as maternal separation. And finally, the use of electrodes on the brain in other than human animals is definitely comparable to shock treatment, which the psychiatric system now calls electroconvulsive therapy, or ECT, used on psychiatrized people. Yes, they still do this. According to psychiatrist Dr. Peter Breggin, the estimate for people undergoing ECT is 100,000 a year, which was based on the available data in 1979, and he claims that there's a lot more going on now, and that the majority of patients who are subjected to this so-called treatment are elderly women because they are, or are at least assumed to be, more vulnerable. According to Dr. Breggin's site, ectresources.org, ECT involves the application of 2 electrodes to the head to pass electricity through the brain with the goal of causing an intense seizure or convulsion. The process always damages the brain, resulting each time in a temporary coma and often a flatlining of the brain waves, which is a sign of impending brain death. And the side effects are typical symptoms of severe head trauma or injury, including headache, nausea, memory loss, disorientation, confusion, impaired judgment, loss of personality, and emotional instability. These harmful effects worsen, and some become permanent as routine treatment progresses. The site also says that memories of important past experiences are commonly impaired or eradicated, including weddings, birthdays, vacations, educational experiences, and housekeeping or professional skills. A sense of self or identity can be demolished, and family members often report that their loved ones was never the same again. Now for the alternatives and actions we can take. If we move beyond psychiatry and into alternative ways to help those in distress, all the testing we do on animals for this system would serve no purpose. But since we aren't there yet, some alternatives to these tests include Dr. Bjorn Eckwell's toxicity tests, which use donated human tissue to measure toxicity and, according to the New England Anti-Vivisection Society, have a precision rate of up to 85% accuracy. Along with this, there have been many advancements towards patient-specific medication through the use of 3D stem cell printing, which, according to an article in The Scotsman from October 2015, the team will be able to print the cells in 3 dimensions without damaging the cell's biological functions, such as their ability to make a wide range of different cell types, such as liver, heart, and brain cells. There are also computer simulations, and according to the National Anti-Vivisection Society, a powerful simulation of the human brain is being developed in what is known as the Human Brain Project. The digital model of the human brain is being constructed from existing scientific data and continually refined by new data as it is collected. Experts on the subject believe this simulator will offer advantages over animal models because scientists will be able to repeat the experiment under as many different conditions as they like, using the same model, thus ensuring a thoroughness that is not obtainable in animals. Some actions many of us can take in supporting the advancements in these and other alternatives include writing letters to legislators, which groups like the National Anti-Vivisection Society can help you with. If you are a foundation you belong to, have the money, you can become a sponsor of the International Foundation for Ethical Research. If taking to the streets is more your style, then I'd recommend checking out the No New Animal Lab campaign, and even though they are focused on the University of Washington, there are many opportunities for folks elsewhere to hold actions. There's also the Gateway to Hell campaign, focusing on ending the transport of other than human animals to laboratories, and their website lists a number of local groups and offers to help you start your own if there is not one nearby. And of course, look to local grassroots groups in your area to see if they are or are willing to organize around this issue. As for alternatives to psychiatry, I want to begin with making this very clear. I do not want to see psychiatric medication criminalized. I support the decriminalization of all drugs, and the last thing I want is to give the state more reasons to lock people up. Dr. Bonnie Burstow summed up the position perfectly when she says, "What we are against is the medical pushing and prescribing of pseudomedicine on one hand, and the government support for and legitimation of such substances and practices on the other." In a great video entitled Grounded Utopianism, that's utopianism with an E, Dr. Burstow puts forth what I consider to be some of the best ideas for alternatives, especially because they are all non-hierarchical. They involve living in a more communal way on a large scale and working on making our societies less distressing. Her other suggestions include multiple treatment options and the ability for the person in distress to always choose what's best for them. She also recommends everyone from an early age be taught the skills to assist someone in distress so everyone could take turns filling that role, instead of those skills being centralized within a system like psychiatry. These suggestions can of course be created within our communities as well, through knowledge and skill sharing of how to help those in distress, and most importantly, asking individuals in your community what they find most helpful during those times, then providing that for them when needed. People could also contact the Ministry or Department of Education for their areas to talk about getting classes on helping people in distress included in the public school curriculum, preferably starting at a young age. I think we need to be careful with this approach under the current system, however, so the classes don't become a type of psychiatric indoctrination. If it is necessary to have some people specialize in this area, I would propose, as many others have, including Dr. Burstow and Robert Whitaker, something similar to the open dialogue approach from Finland. Daniel Mackler documents this approach in his film Open Dialogue, which is available for free online. According to Daniel, it's getting the best results in the developed world for first-break psychoses. The basis for this approach, according to Daniel, is an open, non-hierarchical conversation that values everyone's voice in the treatment, especially the client's. Therapists work together and also openly discuss their thoughts and feelings with each other while the client is present and encouraged to add to the conversation. And they will also include the client's family in these conversations if that is what the client wants. They allow people to always have the ability to choose whether or not to have therapy, to choose the type of therapy, and to choose where that therapy will take place. And they allow people to end a session at any time. The therapy itself is less focused on finding a solution and is more about making sure the client is heard and understood, which ends up leading to the best solution for the client. And much like alternatives to vivisection, there are many opportunities to fund alternatives to psychiatry. One example, which, as an anti-capitalist, I feel a little strange promoting consumerism, but if you are going to order something online anyway, why not see if it is available through madeconomy.com, which is similar to Amazon and eBay, but with all the profits going to mental health projects that are outside the system. For actions, if you're in the Greater Toronto area of Ontario like me, I'd recommend looking into the Coalition Against Psychiatric Assault. If you are elsewhere, both the Icarus Project and Mind Freedom International provide information on chapters and affiliates, as well as offering to help folks start up their own. Many areas also have MAD Pride groups, and many campuses have MAD student societies, which may not always be anti-psychiatry, but they often engage in actions that can work towards that end. Finally, I think these two movements can work together on quite a few issues. First, any anti-psychiatry action, by that I mean any action that brings us closer to ending the psychiatric system, also brings us closer to ending the torture of other than human animals that are experimented on for that system. Other examples are opposing the companies that manufacture and test psychiatric medications on other than human animals. The major ones have offices in many countries, which would make good protest targets. Protesting and outreach on university and college campuses that perform vivisection and train future vivisectors in psychiatric-related programs with the hope of deterring students from these programs and vivisection in general. Protesting meetings and events held by groups like the American Psychiatric Association, and protesting the development of new labs. In conclusion, given that both psychiatry and vivisection are based on and justified by what I would call unreliable pseudoscience, and as I have shown, both are inherently oppressive and cause incarceration and similar types of suffering, given that both are seen by most people as necessary and beneficial to society because of the lies they tell the public, given that these industries have many ties to each other and that the end of psychiatry will also mean the end of vivisection for that system, given that the way forward through the further development of alternatives and phase-out of current systems for both are similar, and given that there are many opportunities for the movements opposing these industries to work together, I think psychiatrized people, other than human animals, and really everyone, would benefit from an allyship between these two movements.